clinical course and complications. If inadequately treated, LPR can result in multiple pharyngeal and laryngotracheal manifestations. The most concerning of LPR complications are those that can result in airway obstruction, and include laryngospasm, paradoxical vocal fold motion, granuloma, stenosis, polypoid degeneration, and even laryngeal carcinoma. 1.15.28 The motion disorders associated with LPR, laryngospasm and paradoxical vocal fold motion, can often be managed with aggressive antireflux therapy combined with speech therapy. Laryngeal lesions such as granulomas and subglottic stenosis often show drastic improvement or resolution with antireflux therapy alone, so, in the case of a safe airway, initial medical management of reflux is generally warranted. Even patients who require surgical intervention for obstructive airway lesions such as polypoid degeneration, laryngeal carcinoma, granulomas, and stenosis, should be started on aggressive antireflux therapy preoperatively and maintained on it postoperatively. Not only do all of these disorders have an association with LPR, but in our experience, if the LPR is not adequately treated perioperatively, the recurrence and complication rates are higher. 27. Granulomas. The etiology of laryngeal granulomas is multifactorial, but LPR should always be suspected as playing a role. Granulomas may result from the combination of acute mucosal ulceration of the vocal process, LPR, and chronic vocal trauma owing to throat clearing or a hard speaking style. By itself, chronic vocal trauma can lead to vocal fold ulcers and granulomas, however, in the majority of cases LPR is a cofactor. The clinician should consider each of the possible factors and address each if therapy is to be effective. In the case of granulomas, effective antireflux therapy is sufficient to allow healing in the majority of patients as long as vocally abusive behaviors also are corrected. Paroxysmal laryngospasm. Laryngospasm is an uncommon complaint, but patients who experience this frightening symptom are usually able to describe events in vivid detail. 29 Laryngospasm is often paroxysmal, and it usually occurs without warning, even awakening some patients from sleep. In some cases, the attacks may have a predictable pattern, such as during exercise. Some patients are aware of a relationship between LPR and the laryngospasm attacks, others are not. In our experience, the majority of patients with paroxysmal laryngospasm respond to some degree to antireflux therapy, but antireflux surgery, fundoplication, may be necessary in patients who fail medical treatment. In a canine model, Laughlin et al. 30 showed that chemoreceptors on the epiglottis responded to acid stimulation at pH of 2.5 or less by triggering reflex laryngospasm. The afferent limb of this reflex is supplied by the superior laryngeal nerve, and nerve interruption abolished the laryngospasm reflex. Laryngopharyngeal reflux-induced laryngospasm may also be associated with paradoxical vocal fold movement and even with sudden infant death syndrome, SIDS. 31. Laryngeal stenosis. Laryngopharyngeal reflux is the primary cause of most cases of subglottic and posterior glottic stenosis. 1.14.28, Figure 9. It can cause, or indefinitely perpetuate, laryngeal inflammation. Using a canine model, it has been shown that intermittent, 3 times per week only, applications of acid and pepsin to the subglottic region following mucosal injury results in non-healing ulceration of the cricoid and subglottic stenosis. 28 Laryngopharyngeal reflux documented by pH testing has been found in 92% of stenosis cases. 1 In the author's experience, aggressive antireflux treatment coupled with gentle, precise surgery is highly successful in these patients. Laryngeal cancer. The most important risk factors for the development of laryngeal carcinoma are tobacco and alcohol. However, LPR also appears to be an important cofactor, especially in non-smokers. 1.32, Figure 10. Koofman 1 reported 31 consecutive cases of laryngeal carcinoma in which LPR was documented in 84%, but only 58% were active smokers. The exact relationship between LPR and malignant changes remains to be proved, but the available data suggest that most patients who develop laryngeal malignancy both smoke and have LPR. In addition, leukoplakia and other premalignant appearing lesions may resolve or significantly regress with antireflux therapy. Tobacco and alcohol adversely influence almost all of the body's antireflux mechanisms. They delay gastric emptying, decrease both upper and lower esophageal sphincter pressures and esophageal motility, decrease mucosal resistance, and increase gastric acid secretion, and thus, strongly predispose one to reflux. Antireflux treatment is recommended for all patients with laryngeal neoplasia, with or without other risk factors. Dysphagia. Laryngopharyngeal reflux can lead to inflammation, edema, and resultant decreased sensation of the larynx and pharynx, which can cause dysphagia with or without globus sensation. 33 Treatment of reflux commonly improves or sometimes eliminates these symptoms. Laryngopharyngeal reflux has also been implicated as a possible etiology for Zenker's diverticulum.